Is the slide visible?
Yes, it is.
Thank you. Good evening, everyone. My name is Dr. Jatin. I'm from batch of 2015. Welcome to the eighth webinar of the Rural Service Bootcamp. So today's session will be uh, on hyponatremia and management of hyponatremia. So we've already covered the diagnostic approach to hyponatremia in the last session. And today's session will be moderated by Dr. Manju Sebastian. And she's an assistant professor in general medicine in SR Medical College, Chennai. Welcome, ma'am. And so, without further ado, we'll be beginning the session. So, just a quick recap on the last session to diagnostic approach. So, I'll quickly go through the flow chart, and I think we've made the links to the last session available. So, if you've not attended the last session, you can go back and attend that later. So, this is a short summary of the last session. So, serum sodium less than 135 is hyponatremia. So, the next thing we check is plasma osmolality. So in plasma osmolality, what we call true hyponatremia is hypotonic hyponatremia. So that is less than 280. Plasma osmolality will be less than 280. So once you've established that it is hypotonic hyponatremia, the next parameter you want to check is urine osmolality. And if urine osmolality is more than 100, it means that urine is getting concentrated and ADH is acting. So it is ADH dependent hyponatremia. And after that, you want to check volume status. So once you assess the volume status, whether it is hypovolemic, euvolemic, or hypovolemic, next thing to check is urine sodium. So in hypovolemic hyponatremia, urine sodium, if it's more than 20, that means there's a renal solute loss, and causes are diuretics and hypoaldosteronism. And if the urine sodium is less than 10, it means that there is extra renal solute loss, such as skin loss, bleeding, vomiting, diarrhea, etc. And under euvolemic hyponatremia, urine sodium will be high, it will be more than 20. And euvolemic hyponatremia examples are endocrinopathies, like cortisol deficiency, hypothyroidism, SIADH. And hypervolemic hyponatremia, urine sodium will be less than 10. So examples of that, examples of hypervolemic hyponatremia are heart failure, liver cirrhosis, and nephrotic syndrome. Having summarized the first class, we'll move on to management of hyponatremia. So before we get into management, I just want to explain two concepts regarding management, which is very important. So brain adaptation to hyponatremia and osmotic demyelination syndrome. So brain adaptation to, so what happens during hyponatremia is, so this is our brain cells and this is the bloodstream. So normally concentration will be the same, and normally osmolality is going to be the same in the blood and the brain. So when there is hyponatremia, uh, because of decreased plasma osmolality in the vascular space, water is going to move into the brain cells, and that is going to cause a swelling. So there's a transient swelling, and that is the initial response to low sodium in the blood. So what happens in chronic hyponatremia is that the brain cells start to adapt to this. The brain cells start to adapt, and the mechanism by which they do this is that the brain cells release. Am I audible? One of the someone is messaged me saying that it's not audible. Ma'am, can you hear me?
Yeah, you are audible. You're audible.
The participants are texting me. Okay. Yeah. So in chronic hyponatremia, there is an adaptation which occurs in the brain cells. So what happens is that the brain cells have certain osmotically active particles called osmolytes inside them. So they begin to secrete these osmolytes. So they include potassium also. So the brain cells start secreting these osmolytes, and as a result, water starts to come out of the brain cells, and it goes into the vascular space and the interstitium. And this is how the in chronic hyponatremia, the brain cells are able to reduce the swelling and prevent swelling even if hyponatremia is present. So this happens over a period of days. So this is not present in acute hyponatremia. In chronic hyponatremia, once the brain cells have the time to adapt, they start secreting these osmolytes outside. And as a result, water will begin to move out of the brain cells, and adaptation will be achieved. Brain adaptation, as I mentioned, this begins on the first day, but it is complete only within it takes several days to complete it. So it occurs in two steps. One step is the initial cerebral brain edema will raise the interstitial hydraulic pressure. So this creates a pressure gradient for the ECF, extracellular fluid movement out of the brain into the CSF. And the next one is what I explained earlier. Brain cells will begin to lose solutes like potassium and osmolytes, and this will lead to osmotic movement of water out of the cells, and that will cause a decrease in brain swelling. So substantial depletion of brain organic osmolytes occur within 24 hours, and additional losses will occur over the next 2 to 3 days. So these processes are reversed with correction of hyponatremia. But the problem is the reuptake of these solutes during correction occurs more slowly than the loss of brain solutes during the onset of hyponatremia. So that is why we have to be careful while correcting hyponatremia. Even if you correct the hyponatremia, um, the brain solids are not going to be the reuptake is not at the same rate as how it went outside. So uh, correction of chronic hyponatremia has to be done very carefully. So what happens if you rapidly overcorrect in chronic hyponatremia? So in this figure, we've depicted chronic hyponatremia. There is an adaptation has occurred. There is no swelling, but there is hyponatremia. So sodium concentration in the blood is low, but osmolality is almost equalized. So what happens? So you saw that the sodium is low and you're rapidly overcorrecting it with 3% NaCl. So in this case, because the osmolality is already almost the same, when you're flushing in a hypertonic fluid, it is going to suck more water out of the brain cells. And as a result, the normal brain cells, which are normal in size before, are going to shrink, and it's going to cause cell death and demyelination. If this were the case in acute hyponatremia, brain cells are swollen, so this wouldn't have led to cell shrinkage. But in chronic hyponatremia, because of the adaptation which has occurred, cells are not swollen; they are of normal size, and flushing in hypertonic fluid is going to suck out more water and result in cell shrinkage and cell death. And osmotic demyelination syndrome, another issue with this is they lead to severe neurologic symptoms, and these symptoms are usually delayed for 2 to 6 days after the overcorrection and can be irreversible also. So initially, you may not notice any symptoms, but the symptoms are delayed. So patients with symptomatic hyponatremia may initially demonstrate neurologic improvement with the correction of serum sodium, but then later begin to show late deterioration due to ODS. So ODS should be suspected in all patients who have risk factors for the disorder and consistent clinical manifestations. So it is likely to be present if overly rapid correction of hyponatremia has occurred. So the complication of treatment of hyponatremia can be reversed by re-lowering the serum sodium. So we'll talk about symptoms and treatment of ODS later. We'll get into management of hyponatremia. The management of hyponatremia. So three things are very important when it comes to management of hyponatremia: duration of hyponatremia, degree of reduction of the serum sodium, and severity of symptoms. So duration of hyponatremia is divided into two: acute and chronic. So acute hyponatremia is anything less than 48 hours. So the more acute the hyponatremia, greater the risk of complications such as cerebral edema and seizures. So acute hyponatremia is more dangerous than chronic hyponatremia, and the need for aggressive therapy is greater in acute hyponatremia. Chronic hyponatremia, if it's anything more than or equal to 48 hours, or if the duration is unclear, we consider the patient to have chronic hyponatremia. So even if you don't know the duration, you're going to consider it as chronic hyponatremia. So the more chronic the hyponatremia and lower the serum sodium concentration, greater the risk of complications from over-aggressive therapy. So in chronic hyponatremia, what we have to be wary of is the complications of therapy rather than the hyponatremia itself. So the greater the risk of complications from over-aggressive therapy, and the greater is the need for monitoring to avoid overcorrection. So we've covered the duration, So degree of hyponatremia. So mild hyponatremia is 130 to 134. Moderate hyponatremia is 120 to 129, and severe is less than 120 milliequivalents per liter. So complications of untreated hyponatremia and complications from overcorrection of hyponatremia are most common among patients with severe hyponatremia. So if you don't treat it also, it's going to be dangerous, and there are potential complications of overcorrecting this hyponatremia also. So mild is 130 to 134, moderate 120 to 129, severe is less than 120. So I had shown this picture in the last class also. So what happens in hyponatremia, brain cells are going to swell up, and because of that, you're going to have certain symptoms. So you can have hyponatremia can be asymptomatic. You can have mild symptoms like headache, irritability, difficulty concentrating, altered mood, and depression. Moderate symptoms include nausea, confusion, disorientation, altered mental status, unstable gait, falls, and tremors. And moderate and mild, the distinction may not be very clear. Moderate and mild symptoms. And severe symptoms, you can have vomiting, seizures, obtundation, respiratory distress, and coma. So severe symptoms such as seizures are relatively common in patients with acute and marked reduction in serum sodium. So there is no time for brain adaptation to occur, and affected patients can develop severe neurologic manifestations, including coma, brainstem herniation, and death. Mild to moderate symptoms, as I mentioned earlier, are relatively non-specific. So it occurs most commonly in patients with chronic hyponatremia and with marked reduction in sodium concentration. So this can result from the brain, again, as we explained earlier, from brain adaptations which alter the composition of brain cells. These adaptations itself can cause some symptoms. And if the serum sodium concentration is extremely low, like if it's less than 110, then even mild to moderate symptoms may be a prelude to seizures. And in patients with acute hyponatremia, even those with sodium concentrations of greater than 120 should be considered ominous and may evolve without warning to seizures, respiratory arrest, and herniation. So if it's acute hyponatremia, even if the sodium concentration is not that low, say it's above 120, even mild to moderate symptoms have to be treated promptly. And some patients may be asymptomatic, particularly those with chronic hyponatremia, so of moderate reduction. And they can have subtle impairments in mentation and gait. And these people have an increased risk of falls and fractures also. So they are often offered chronic therapies to normalize the sodium concentration. And chronic therapies include oral urea salt tablets, furosemide, or vasopressin antagonists. So we've gone through duration, we've gone through degree of reduction of hyponatremia, and the severity of symptoms also. So to determine the need for hospitalization. So patients at high risk for complications from untreated hyponatremia and those at high risk for complications from overcorrection should be treated in the hospital. So this also includes assessment of the patient's neurologic condition, accurate measurements of urine output, and sodium concentration. So generally, we'll admit patients with acute hyponatremia, and if they have a severe reduction in sodium, also we'll admit them. And if they're symptomatic, also we will consider admission. So we'll be going through a flow chart later, which will make these things clearer. So before we go into the flow chart, we should know what the goal rate of correction is. So the goal rate of correction is 4 to 6 in a 24-hour period. So we have to raise the serum sodium concentration by 4 to 6 milliequivalents per liter in a 24-hour period. So in symptomatic patients with acute hyponatremia or in patients with severe symptoms, this goal should be achieved quickly, that is in 6 hours or less. So thereafter, the serum sodium can be maintained at a constant level for the remainder of the 24-hour period. So our goal rate is 4 to 6 in 24 hours. If the patient is having acute symptomatic hyponatremia or if the patient is having severe symptoms, this goal should be achieved in 6 hours or less. But then it should remain at that level of increase for the for the remainder of the 24-hour period. So after this, you don't you don't want the sodium to go beyond that level of increase. So whatever the hyponatremia is, the goal is 4 to 6. You should not go beyond that level. So as I mentioned earlier, acute hyponatremia is a dangerous condition, but it is less dangerous to treat. Chronic hyponatremia is a less dangerous condition, but it is dangerous to treat, as in you have to monitor the patient and be careful while treating chronic hyponatremia. So regarding the goal rate of correction, again, 4 to 6 increase appears to be sufficient to reverse most severe manifestations of hyponatremia. So actual correction often exceeds what is intended. So that's why we stick to this safe level of increase of 4 to 6. And most cases of ODS have occurred in patients with severe hyponatremia, whose serum sodium concentration was raised by more than 10 to 12 within 24 hours, or more than 18. So guidelines have kept changing on this. Earlier, the goal rate was around 10 or 12, I think. Then it was 8. So right now it is 4 to 6. So again, this is another thing, which is very important. The therapeutic goal on any given day should not be a predefined serum sodium level. So patient might have hyponatremia of 120 or 118. So a lot of us might have, even I had this fixation. Okay, you want the sodium at 130. So your goal should not be achieving 130 as soon as possible. Your goal should be uh, getting an increase of 4 to 6 and not beyond that. 4 to 6 over 24 hours. So after that, you don't want to increase the sodium beyond that on the same day. In the next 24 hours, you can achieve another 4 to 6. So you can't directly shoot up the sodium to 130. There is also inherent imprecision of serum sodium measurements, particularly at low concentrations. So therapeutic goals should not be too close to rates that can result in patient harm. So the 24-hour goal may be achieved in the first few hours, since it's the daily change rather than the hourly change in serum sodium that is associated with ODS. So even if you achieve this 4 to 6 milliequivalents per liter of increase in the first few hours, it is okay. You just need to maintain it for the total of 24 hours, because it is a daily change which is more associated with complications rather than the hourly change. So for other goals of therapy are prevent further declines in sodium concentration, decrease the intracranial pressure, and decrease the risk of developing brain herniation, relieve symptoms, and avoid excessive correction. So regarding preventing further declines, say in acute hyponatremia due to self-induced water intoxication and IV fluid administration and surgery-induced SIADH. So these are two conditions where sodium can decline even after presentation. So in acute hyponatremia due to self-induced water intoxication, this is basically, if you've listened to the last class, it is basically due to increased volume being absorbed from the GIT, and because of that, dilution can occur and hyponatremia can happen. So here, the entire water may not have been absorbed from the GIT. So the sodium levels can dip even after presentation. So you have to be careful about that. And in IV fluid administration and surgery-induced SIADH, large volumes of isotonic fluid will happen during IV fluid administration. There will be volume expansion and increased sodium excretion in the urine. And if ADH is high, sodium excretion will happen in concentrated urine. So try to avoid isotonic saline and surgery-induced SIADH also, because after surgery due to stress-related factors, ADH will be high and hyponatremia can occur. And regarding preventing brain herniation, again, as I mentioned earlier, acute hyponatremia due to massive water ingestion, the sodium levels can dip even after presentation, so you have to be careful about that. And women and children also can present with acute post-op hyponatremia. And you have to be careful in hyponatremic patients where there is an intracranial pathology, like recent traumatic brain injury, recent intracranial surgery or hemorrhage, and intracranial neoplasm or space-occupying lesion. And when sodium is less than 130, even mild non-specific symptoms can rapidly progress. Also, concurrent hypoxemia can also exacerbate the cerebral edema. So take care of the saturation levels also. So regarding overcorrection also we've talked about. So this flowchart is very important. So first we'll deal with acute hyponatremia. So acute hyponatremia, it is always better to admit the patient. So there are two types, symptomatic, asymptomatic. So whether the patient has mild, moderate, or severe symptoms, you admit the patient, and the next step is 3% saline, hypertonic saline. So how much 3% saline to give? 100 ml bolus of 3% saline. You can give it over 10 minutes if the patient is symptomatic. So a lot of us will be apprehensive to give like this volume of saline, hypertonic saline over 10 minutes. But this is accepted standards, and you can actually give the 3% saline over 100 bolus of 3% saline, 100 ml bolus over 10 minutes. And you can also repeat up to 2 additional doses if required. So you can give a total of 300 ml of hypertonic saline. So when you're giving this, another thing is you have to monitor sodium hourly, ideally, till an increase of 4 to 6 occurs. So once this increase of 4 to 6 has been achieved, you can stop hypertonic saline. So say a patient is actively seizing, and so patient is symptomatic and sodium is 120. You can go ahead and give 3% saline, 100 ml bolus over 10 minutes. The only thing is that you have to monitor sodium hourly. And once you achieve that increase of 4 to 6, you can stop hypertonic saline. And general measures will include your fluid restriction and salt-based diet and all those things. Asymptomatic patients, so there are two scenarios. One, one is where autocorrection can be happening due to water diuresis. So in this case, you have to monitor sodium hourly. Okay, so uh, water diuresis, as an example, is again increased water ingestion. So at later points also the sodium can drop. So initially you want to monitor sodium, and in this case monitor sodium hourly. And if there is an increase later, then it's okay. If there's a further decline in sodium, that is due to, for example, delayed absorption of ingested water, that means that there is no autocorrection happening. So in this case, you want to go ahead and give a 50 ml bolus of 3% saline, and obviously follow general measures. And if there is no autocorrection due to water diuresis, as I mentioned here, 50 ml bolus of 3% saline, monitor sodium hourly to determine the need for further bolus and general measures. So if it's symptomatic, you can give 100 ml bolus of 3% saline over 10 minutes, up to 2 additional doses. So a total of 300 ml can be given. So you have to monitor sodium hourly, and once you reach an increase of 4 to 6, you can stop sodium. If it's asymptomatic, if there is a further decline, asymptomatic, and there is an autocorrection due to water diuresis, you can monitor, wait and watch, you can monitor. If there's a further decline later, then you can give a 50 ml bolus of 3% saline. If there is no autocorrection, you can give a 50 ml bolus of 3% saline, monitor sodium hourly. Once you reach an increase of 4 to 6, you can stop. So this is just explaining the previous flow chart. Management of acute hyponatremia depends on the presence or absence of symptoms. So acute onset hyponatremia is dangerous because it can result in life-threatening cerebral edema. There is no time for the brain to adapt. So even mild symptoms in acute hyponatremia are a medical emergency and requires prompt and aggressive treatment with hypertonic saline. So don't hesitate to start hypertonic saline in these patients. So some people say that you need a central line for starting hypertonic saline. This is not necessary. Peripheral line is sufficient. So this is the same thing which is explained in the flowchart: 100 ml bolus of 3% saline over 10 minutes. And in asymptomatic patients, 50 ml bolus of 3% saline if the sodium is not autocorrect. And monitoring is very important in both scenarios. If possible, monitor every 1 to 2 hours. So in chronic hyponatremia, this is a flow chart explaining management of chronic hyponatremia. So in chronic hyponatremia, if you have severe symptoms, you can admit the patient. So again, the management is the same: 100 ml bolus of 3% saline over 10 minutes, up to 2 additional doses. That is a total of 300 ml if required, and monitor sodium hourly till increase of 4 to 6, and general measures. If the patient does not have any severe symptoms, chronic hyponatremia with no severe symptoms, say the patient has a known intracranial pathology, then there is an increased risk of herniation because with minimal amount of swelling itself, the space in the brain will decrease and herniation can happen. So it's better to admit these patients also, and management will follow the same uh, protocol as before, 100 ml bolus or 3% saline over 10 minutes. If the patient has chronic hyponatremia with no severe symptoms and sodium is less than 120, so degree of reduction of sodium is severe. So in this case also you admit the patient. So sodium is less than 120. So from history, you will get to know whether this was due to water intoxication. So if that is the case, there is a chance of this hyponatremia autocorrecting after some time. So take general measures and monitor the sodium every 6 to 12 hours. Say if the patient is edematous, if the patient is in heart failure or has cirrhosis, then the protocol is 3% saline infusion at 15 to 30 ml per hour. So I think if you give your 100 ml 3% saline, at this rate, it will be around 3.5 to 6 hours. So that is the rate for chronic hyponatremia, no severe symptoms, but sodium is less than 120. So degree of reduction of sodium is severe and patient is edematous. So you start 3% saline at 15 to 30 ml per hour. And you can also start the patient on IV furosemide, 40 milligrams BD. So once you've started both these things, you can monitor sodium every 2 to 4 hours. And based on the values which you get from monitoring, you can adjust the rate of 3% saline to achieve a 24-hour increase of 4 to 6. You can also titrate furosemide to prevent severe hypovolemia. So your objective of giving 3% saline is to increase the sodium concentration, and your objective of giving furosemide is to decrease the volume load. Also, general measures is common in all scenarios. General measures have to be followed here as well. So say patient is having chronic hyponatremia with no severe symptoms and sodium is less than 120. And patient is not edematous. There is no history of water intoxication. Again, you can start the patient on 3% saline infusion at 15 to 30 ml per hour. In this case also monitoring is important, but you can monitor every 4 to 6 hours. And you can adjust the rate of 3% saline to achieve an increase of 4 to 6 per 24 hours. And gentle measures have to be followed. Now another scenario is chronic hyponatremia, no severe symptoms, but sodium is more than 120. So the degree of reduction is not that severe. It is moderate to mild. Sodium is more than 120. So these patients can be asymptomatic and can be symptomatic also. So if these patients are symptomatic, say they have mild to moderate symptoms, admit these patients and monitor sodium every 4 to 6 hours and follow general measures. If the patient is asymptomatic, that is patient having chronic hyponatremia, sodium is more than 120 and patient does not have any symptoms, you don't need to admit the patient. You can monitor them on OP basis and advise general measures. So again, chronic hyponatremia, this is basically explanation of the flow chart. And it is better to keep these scenarios in mind because of, so there are two things which we have to be careful about. So for those cases where the cause of hyponatremia is rapidly reversible and patients who are at a high risk of developing osmotic demyelination syndrome. So according to, I think in foreign countries, we simultaneously initiate desmopressin to prevent overly rapid correction, but usually we don't follow it here. So we need to be careful if we are overcorrecting sodium in these cases. So the reason why is rapidly, first I'll explain about rapidly reversible causes. So hyponatremia due to true volume depletion. So in true volume depletion, the cause is rapidly reversible. Once you replace the volume, your ADH is going to become inhibited and hyponatremia will get corrected very quickly. So when you're managing this kind of hyponatremia, there is a risk of overcorrection. So that is why you have to be careful in true volume depletion. And in hyponatremia due to adrenal insufficiency, if you administer adrenal steroids, that is also going to inhibit ADH secretion and it's going to produce a water diuresis. So hyponatremia in this case also, once you address the cause, will be easily reversed. And in SIADH of like relatively transient nature, like post-surgical patients, or if SIADH is due to a drug or pain, once the stimulus is removed, SIADH is also going to stop. So hyponatremia is going to get corrected quickly in this case also. And the other thing is thiazide-associated hyponatremia. Once you remove the offending drug, hyponatremia is going to get reversed. So in all these cases, there is a risk of overcorrection. So according to protocol which is followed elsewhere, like along with 3% hypotonic saline, you give desmopressin also to prevent this rapid overcorrection. So desmopressin is basically like a substitute for ADH, and it is going to absorb water. So it is going to prevent overcorrection. And other cases where there's a high risk for overcorrection is patients at risk for osmotic demyelination syndrome. So you have to be careful while correcting hyponatremia in these patients also. So patients at high risk for ODS are those with obviously chronic hyponatremia. Along with that, serum sodium of less than or equal to 105. So very severe hyponatremia, very severe reduction of sodium in the serum, and concurrent hypokalemia. If concurrent hypokalemia is present, if the patient has a history of chronic alcohol use, and if there is a history of malnutrition, and if there's a history of liver disease and hypophosphatemia. So these conditions are important to keep in mind. There is a higher risk of ODS in these conditions. So in these conditions, and in conditions where the cause of hyponatremia is rapidly reversible, it is better to keep a closer eye on the sodium levels, and there is a risk of overcorrection, which is more than in other cases. So we covered management in acute and chronic conditions, chronic hyponatremia. So the additional measures which you have to take in all these cases are identify any medications which could be causing hyponatremia, like your diuretics, and identify any other drugs which the patient is taking. So very detailed history is important, and discontinue those drugs unless there is no reasonable substitute, and stop the medication. And unless there is no reasonable substitute and stopping the medication would cause serious harm, you can discontinue these drugs. And another recommendation is reduced intake of electrolyte-free water. So we are restricting fluid intake. And the most important step is identifying and treating the cause of hyponatremia. So this was covered in our diagnostic approach in the last class. Subsequent therapy of chronic hyponatremia. So although the eventual goal, as I mentioned earlier, is normalization of serum sodium concentration, therapeutic goal should not be a predefined sodium level. Your goal is to increase the sodium level by 4 to 6 daily. Small 4 to 6 daily increases in the sodium concentration are sufficient, no matter how low the original serum sodium concentration is. So larger increases offer no therapeutic advantage and only increase the risk of neurologic complications. So as I mentioned earlier, once the daily correction has been achieved, infusion of 3% saline should be discontinued for the remainder of the day. If the serum sodium begins to fall again, hypotonic saline can be resumed as needed. So that is why monitoring is needed. And regarding monitoring, besides the serum sodium concentration, urine output is also very important. So if the urine output is increasing, urine osmolality, urine sodium, urine potassium, if these tests are available, can also be measured. So an increase in urine output and a decrease in urine cation concentration can signify that the rate of correction is accelerating. So as I mentioned earlier, water diuresis can mean that, okay, the rate of correction is sodium is getting corrected, and you need to make sure that the serum sodium is measured more frequently. If the risk of overly rapid correction is low, frequency of measurements of all these parameters can be taken at a less frequent rate. So in acute hyponatremia, you have to monitor. Ideally, we should monitor hourly, and frequency of monitoring can be decreased once you reach your goal of raising sodium by 4 to 6. In chronic hyponatremia, patients should have the serum sodium measured often enough to ensure an appropriate rate of correction and to allow the clinician to react quickly. But this is less often than acute hyponatremia. You can afford to check sodium every 4 hours. So fluid restriction, generally fluid intake should be less than 800 ml per day. So we are trying to restrict the fluid intake to less than the urine output. And in the setting of, but this is all, I had mentioned this particular scenario in the last class, cerebral salt wasting. So you have to be careful about cerebral salt wasting because this is a volume contracted state, so fluid restriction is not indicated in this condition. So be careful about cerebral salt wasting. And these patients, since they are usually volume depleted, further fluid restriction can be dangerous to the patient. But otherwise, in these cases, general measures include fluid restriction. So you can also, if urine electrolytes is a test which is available to you, you can actually measure the effectiveness of fluid restriction. So if you add urine sodium plus urine, sorry, there's a mistake. Urine sodium plus urine potassium, there's a mistake in the slide, and divided by serum sodium, a ratio less than 0.5 suggests that serum sodium concentration will rise with fluid restriction. So you can actually predict if fluid restriction is going to work for your patient or not. Another thing we have to keep in mind is a lot of patients with hyponatremia will have hypokalemia also. So potassium is also an osmotically active, is as osmotically active as sodium. So while if you're giving a potassium correction, this can also raise the serum sodium concentration and osmolality in hyponatremic patients. So while giving the potassium correction, be careful. Try to watch for the rise in sodium, which may not be expected. So whether you treat potassium hypokalemia or hyponatremia depends on the symptoms. Which one you treat first depends upon the symptoms. But just keep in mind that while giving potassium, serum sodium concentration can raise potassium correction itself can raise the serum sodium concentration. So this is also another type of medication which we'll commonly come across in rural centers, vasopressin receptor antagonists. So vasopressin receptor antagonists are an alternative or possible addition to measures such as fluid restriction and sodium chloride administration. So there are different kinds of ADH or vasopressin receptor antagonists. So there are receptors which act at the V2 receptors, and there are receptors which act at other receptors like V1A and V1B also. So your V2 receptors are those receptors which are responsible for your antidiuretic response. And V1A is responsible for vasoconstriction and V1B for ACTH release. So what vasopressin receptor antagonists do is that they're going to result in selective water diuresis. So normally your ADH will act at the V2 receptors in the collecting duct to reabsorb water, but your vasopressin receptor antagonist is going to act there and inhibit ADH action. And because of this, there is a selective water diuresis. So sodium and potassium excretion is not effective. So this is basically loss of free water. And because of that, there is a correction of hyponatremia because you're concentrating the bloodstream. And however, these medications can increase thirst significantly. And because of that, the patient may consume fluids, and this can limit the rise in serum sodium. So that is one thing which you have to keep in mind. So vasopressin receptor antagonists, which selectively block the V2 receptor, are tolvaptan, mozarvaptan, satorvaptan, lixivaptan. So tolvaptan is very common. We commonly come across tolvaptan, and conivaptan is an intravenous vasopressin receptor antagonist which blocks both V2 and V1A receptors. So indications of when to use vasopressin receptor antagonists, indications are euvolemic hyponatremia, such as ADH, SIADH, and hypovolemic hyponatremia, uh, like heart failure, or when fluid restriction fails. Contraindications will include liver disease because it can potentially lead to liver failure or death. And it has also been seen to worsen renal function in polycystic kidney disease. So you have to be careful while using it. So contraindications are liver disease and severe kidney disease. So just keep in mind, hypovolemic hyponatremia can also be something like cirrhosis. So in that case, you don't want to give vasopressin receptor antagonists. So it's usually heart failure and euvolemic hyponatremia, SIDH. So limitations of vasopressin receptor antagonists are it should not be used in any patient for longer than 30 days. So that is what has been recommended. And if there are any symptoms that are suggestive of liver injury like fatigue, anorexia, right upper quadrant discomfort, dark urine or jaundice, LFTs have to be promptly performed. And These drugs can also cause overly rapid correction. So rarely ODs can occur, but because of this risk of overly rapid correction, we have to keep the patient admitted. Hospitalization is required to initiate or reinitiate the therapy if it is discontinued early. So to start this drug, patient has to be admitted. So adverse effects are increased thirst, dryness of mouth, increased urination, and dehydration, and as a result, hypotension and syncope, and GI bleed. GI bleed is because earlier we mentioned that V1A receptor is responsible for vasoconstriction. So if vasopressin receptor antagonist is going to, which act on V1A receptors are going to act there, vasoconstriction is going to be inhibited, and there is an increased risk of GI bleed, variceal bleed in patients with liver cirrhosis. And other adverse effects are hypernatremia, hyperkalemia, and rarely ODS. Okay. So regarding isotonic saline, okay, so if the patient has true volume depletion, we try to replete the volume with isotonic saline. But there are two things which you have to keep in mind when we are giving isotonic saline. So once we correct the hypovolemia, in true hypovolemia, once we correct the fluid deficit, your ADH is going to, stimulus for ADH is removed. So because of this, excess water will be excreted in dilute urine. ADH won't. Once hypovolemic correction happens, ADH will be stimulus for ADH is gone. So water stops being reabsorbed from the urine, and excess water is excreted in dilute urine. So in some patients, when we are correcting the hyponatremia with isotonic saline, uh, it can cause overly rapid correction of hyponatremia, and this can lead to ODS. So be careful while giving isotonic saline in true volume depletion. Obviously, you have to replete the volume with isotonic saline, but then you also have to be careful about the risk for overcorrection once the volume has been repleted. And obviously, do not use isotonic saline in edematous patients like heart failure. So your infused saline will be retained, and there will only be a minimal increase in serum sodium concentration. And because of your retained water, it's going to exacerbate the edema. And do not use it in SIADH also. SIADH, the patient is euvolemic, and water is going to get retained, and your ADH secretion in SIADH is not physiologic, it is independent of that. So there is persistent action of SIADH even if you're giving more volume. So water is going to get retained. So do not use it in edematous patients and in patients with SIADH. So there is also a form later, earlier in the flowchart, we went through like the range for sodium infusion. But there is also a formula for how much sodium to be infused. So the formula is increase in serum sodium after 1 liter of infusate. So if you know the sodium concentration in the infused fluid, say it is 3% hypertonic saline or isotonic saline, whatever fluid you're using, if you know the sodium concentration in that, if there is any potassium in the fluid you're administering, you have to add that and subtract the patient's serum sodium concentration from that and divide it by total body water plus 1. So this will give you the increase in serum sodium concentration if you administer 1 liter of your fluid of choice. So even though these many textbooks give this formula, this formula doesn't really account for any ongoing electrolyte or water loss, and it's only a rough guide. And formulae have also been many formulae have also been shown to overcorrect the sodium levels. So in practice, we usually just go with a fixed rate and not the formula. So coming back to osmotic demyelination syndrome. So as I mentioned earlier, the symptoms are delayed for 2 to 6 days after overly rapid elevation. So symptoms can include dysarthria, dysphagia, paraparesis, quadriparesis, behavioral disturbances, movement disorders, seizures, lethargy, confusion, disorientation, obtundation, coma. And severely affected patients can become locked in. That is, they are awake but are unable to move or verbally communicate. So osmotic demyelination syndrome was earlier called pontine demyelinolysis because of it was thought to affect the pons only, but now we know that it can affect other extrapontine regions also. So pontine involvement can cause speech abnormalities, and it can also affect the corticospinal tract and the corticobulbar tract and cause hyperreflexia, bilateral Babinski signs, brisk jaw jerk. So these things are common. And other symptoms are increased muscle tone, facial weakness, rooting reflexes, and extrapontine involvement can cause psychiatric disturbances, catatonia, postural limb tremors, myoclonic jerks, and even a Parkinsonic picture with choreoathetosis or dystonia. So, because of swallowing dysfunction in ODS, that can also lead to aspiration pneumonia and respiratory failure. So, imaging, when it comes to imaging for for ODS, MRI is ideally what we need to do, but if it is unavailable, CT can also be done, but it is less reliable. But the problem with imaging is that it may not become positive for as long as 4 weeks after disease onset. And in some patients with a clinical course consistent with ODS, sometimes like no lesions have been documented by MRI. So initially a negative radiologic study in a patient who develops neurologic symptoms after overly rapid correction, this does not exclude ODS. So if neurological findings persist, you have to repeat an MRI over several weeks. So earlier detection may be possible with certain MRI techniques such as diffusion weighted imaging, but again, negative MRI does not rule out ODS because it can turn up very late. So you have to patient symptoms have to be watched out for, and you have to keep a tab on overcorrection. So as I mentioned earlier, again, patients at high risk for ODS are those with chronic hyponatremia, very severe hyponatremia of less than or equal to 105, concurrent hypokalemia, history of alcohol use, malnutrition, history of liver disease, hypophosphatemia. And low risk for ODS will be a patients presenting with acute hyponatremia that developed over a few hours. The acute hyponatremia itself will be dangerous to the patient, but then there is a risk for ODS is very low. So there should basically there should be little hesitation to treat acute hyponatremia with hypertonic saline even when symptoms are mild, because you don't need to worry about ODS in such cases. Uh, just to briefly go through like what to do if patient has osmotic demyelination syndrome. So you have to basically you have to relower the regimen, serum sodium regimen. So you have to bring the sodium down. So one thing you can give is give 5% dextrose to the patient. So 6 ml per kg of lean body weight infused over 2 hours. So this will lower the serum sodium by approximately 2 milliequivalents per liter and repeat till the therapeutic goal is achieved. And another thing is desmopressin. So I'm not going into much detail about this because yeah, and goals of therapy in ODS also is less than 8 in a 24-hour period and less than 16 in 48-hour period. So this is how much you should decrease sodium by if you're suspecting ODS and if there was overcorrection. So you can use 5% dextrose and desmopressin also to prevent overly rapid correction. But I'm not sure how available desmopressin is going to be in our bond centers. So it is good to know, and you can read up about this later at your own time. Okay. So that has brought us to the end of management. So before we get into case scenarios, I'll just quickly go through the flow chart once again for acute and chronic. Yeah. So in acute hyponatremia, if it's symptomatic, regardless of severity of symptoms, admit the patient. You have to treat the hyponatremia aggressively. 3% saline, 100 ml bolus over 10 minutes. You can give up to 2 more if required, and monitor sodium hourly. And you can stop once you've achieved an increase of 4 to 6 and monitor the sodium. If there is a further drop, you have to restart 3% saline and gentle measures. Asymptomatic patient, if there is an autocorrection, keep monitoring the sodium. till an increase of 4 to 6 is achieved. If there is a further decline in sodium, that means there is no water correction. So you have to start with 50 ml bolus of 3% saline. If from the beginning itself you know there is no water correction due to water diuresis, you can start the patient on 50 ml bolus, 3% saline, and monitor the sodium hourly. And in chronic hyponatremia, if the patient has severe symptoms, admit the patient. 300 ml bolus or 3% saline over 10 minutes. You can give up to 2 additional doses, monitor sodium till increase of 4 to 6 is achieved, and general measures. If patient is having chronic hyponatremia with no severe symptoms, but the patient is known to have an intracranial pathology like recent TBI or space occupying lesion or intracranial neoplasm, admit the patient and treat with 100 ml bolus or 3% saline. If the patient is having chronic hyponatremia with no severe symptoms and sodium is less than 120, symptoms are not severe, but the degree of reduction is severe. So in this case also, you admit the patient. If there is a water intoxication, you can monitor the sodium and wait. If the patient is edematous, patient is in heart failure, patient has cirrhosis, you can start 3% saline infusion at 15 to 30 ml per hour, along with IV furosemide 40 BD. Both the rates of saline and the dose of furosemide can be titrated to achieve an increase of 4 to 6 per 24 hours. And if the patient is not edematous, you can just start the patient on 3% saline infusion at the rate of 15 to 30 ml per hour and monitor sodium every 4 to 6 hours and adjust the 3% saline, a rate of 3% saline to achieve a 24-hour increase of 4 to 6 and follow general measures. If the patient does not have severe symptoms, but sodium is more than 120 in chronic hyponatremia, if it's asymptomatic, more than 120 means you can monitor the patient on OP basis and recommend general measures. If it's symptomatic, that is, there are mild, moderate symptoms, you can admit the patient and monitor. So that brings us to the end of management. So now we'll get into some case scenarios, uh, which will help us put what we've learned into practice. So Dr. Manju will be taking over right now. So ma'am, if you can, are the
Thank
slides
you.
visible?
Yeah, there is.
I will just put the slide show once.
So good evening, everyone. Jatin has dealt very exhaustively on hyponatremia. So majority of what I say right now will be a repetition, but hopefully it will serve to summarize what has been a very exhaustive class. So we'll go to the case scenarios.
Okay. Sorry. Yeah.
So here you have a case. He's a middle-aged male who is post-op. We've been given his weight as 60 kg, and he has been receiving lots of fluids in his post-op period. They've given it as 5% dextrose, and at the same time, he has been allowed a liberal oral intake. And on the third day of his post-op, he becomes confused, develops seizures, and is found to be stuporous but euvolatile. So couple of investigations have been given here. You find his serum sodium is low. It's he has severe hyponatremia. His potassium is normal, and his osmolarity has been given to you as well as the urine osmolarity. So going to the flow chart, we know that what we have to do. So he has severe hyponatremia. He's symptomatic. We're assuming that preoperatively all his lab workup was normal, and so what has developed is an acute hyponatremia, acute symptomatic severe hyponatremia. So based on the serum osmolarity, you know that he falls in the category of hypotonic hyponatremia, which is what you're expecting. Most of the cases you will see will be hypotonic type. And again, as Jatin had already said multiple times, urine osmolarity here, you can find that the urine osmolarity is quite high. It's more than 100, which tells us it's an ADH dependent cause for the hyponatremia. Again, most of the cases we'll see will fall in this category with ADH dependent. ADH suppressed, very few scenarios. For instance, a patient with polydipsia, primary polydipsia, which is seen in cases like psychotic patients or use of certain recreational drugs. Ecstasy is said to cause this. So most of the cases we'll see will fall under the ADH dependent, like this patient. So once you have found out that patient is ADH dependent, next thing you're going to do is assess the volume status. Again, this has been told in the scenario. It's told that he's euvolemic. So here the options are very simple. He's euvolemic. We haven't been told about the urine sodium, but the possibilities here are only SIADH or a cortisol deficiency. Again, assuming that the patient was clinically fine preoperatively, this is an acute episode, it's unlikely to be cortisol deficiency, which brings us to the possibility of an SIADH. Now, why did he develop SIADH? This is a very common scenario you will see, especially in post-op patients, where the post-operative period, due to severe pain, there will be an inappropriate and persistent increase in ADH secretion. So this will cause a sudden hyponatremia. This particular patient went into a very severe hyponatremia, possibly because of the choice of fluids that was given to him in the post-op period. We were told that he was given lots of 5% dextrose and he was allowed a liberal oral intake. So probably what would have been a mild hyponatremia was aggravated by the hydration that happened for this patient. So we can go to the next slide. Well, before you consider, now you've found out the cause for hyponatremia for this patient, before you decide on how you want to treat the patient, you need to know what infusate you're going to use for the patient. So this table is going to be very important for you practically. What is the sodium concentration in the fluids that we commonly use? Please note that the concentration of sodium is given per liter of the fluid. For instance, 3% hypertonic saline is available as a 100 ml bottle, but this is given as 1 liter. So essentially, when you give 100 ml of your 3% saline, you will be giving the patient around 50 millimoles of sodium. If you're giving normal saline usually comes as a 500 ml pint. So in that case, you'll be giving the patient around 77 millimoles of sodium. And here you can see that 5% dextrose has absolutely no sodium. So this patient was actually being given free water. That will explain why he developed such severe hyponatremia. So the next slide will show the patient has hypotonic hyponatremia. We're thinking it's post-operative because one, his ADH secretion was inappropriate, probably due to pain. And second thing was the fluid management, the dextrose that pushed him into the severe hyponatremia. So now we want to correct the hyponatremia for this patient. Patient is having symptoms. He's stuporous and he had seizures. So it's an acute condition and we need to acutely manage it. So the flow chart that Jatin had gone into great detail about giving the bolus of the patient. Here, definitely this is a patient who qualifies for giving your bolus of your 3% NaCl. Now, just highlighting about this Madius formula, AM formula, majority of the textbooks will give a lot about this formula. But right now, when we manage, we don't, like Jatin explained, we don't use this formula very commonly. But still, it serves as a rough guide to know about how much of correction we can expect to the fluid that we are giving. So basically, it tells us the change in sodium that will happen depending on the infusate we're using. Suppose I want to give the patient 3% NaCl. I know the concentration is 513 millimoles of sodium. So based on this patient with a sodium of 110, how much change do I expect? So it's 1 liter will produce around 11 milliequivalents change of sodium in this patient. But like he explained, this formula is very vague, it's very abstract because the first thing is we are seeing this calculation of the total body water here. Because it's a male patient, we are assuming that 60% of their weight will be water. If it's a female, we would have used 50%. So that is a very rough guide. Of course, depending on the patient's age, the patient's actual weight, all this will vary. The other thing is certain formulas will bring in a correction of potassium. In this particular one, we have not used potassium. Potassium is also an important electrolyte which maintains the tonicity. So this formula has completely disregarded potassium. And the third thing is this is completely disregarding the urinary loss that will happen in the patient. So this is just assuming I'm giving the person 3% NaCl and the patient is not losing any extra sodium in their urine, which will never be the case. So depending on the amount of fluid we give the patient, the amount of sodium that goes in urine will also vary. So the AM formula is a very abstract way of calculating, but still it'll help us to know what to anticipate. So that's why I have included it here. So with 1 liter of your hypertonic saline, you're expecting a rise of 11 milliequivalents. Each of the NaCl, 3% NaCl comes as a 100 ml bottle. So each bolus that you give is going to produce a rise of around 2 milliequivalents. Again, very, very approximately. So based on what we have learned so far, we know that in acute hyponatremia, our target is not to rise anything more than 8. Again, like Jatin explained, this cutoffs keep changing. So previously, it was considered acceptable to rise it up to 8 to 10. When I was studying, it was 8 to 10. But now guidelines are giving 4 to 6, 6 to 8. Different textbooks might give slightly different values for that. But generally, it is accepted now that not more than 8 milliequivalents in a period of 24 hours. So if I'm going to give my bolus, I need to know that each bolus I give is going to rise it by 2 milliequivalents. And that is a very abstract calculation. This AM formula will usually overcorrect it. So it will be usually more than 2, what will happen for the patient. So even though the guidelines have given that you can give the patient up to 300 ml bolus of 3% NaCl, you'll have to remember that your target is around 4 to 6 milliequivalents and you're not going to exceed that. So when we're giving bolus, the flow charts that have been depicted are all showing an ideal scenario where you get a sodium report in an hourly basis. You're able to follow it up, most of which will not be available in reality. So in that case, you will have to use the AM formula to get an idea that each bolus I give will have a change of around 2. So I cannot give more than 2 bolus at a time. I need to recheck my sodium and confirm that I have not exceeded my limit. The next slide. So this is another variation of the AM formula, like it's a derivation of that. Basically, calculate the sodium deficit. So how much do you want your sodium to increase by? Definitely not more than 8. So the total body water in this patient, a 60 kg person, a male patient, will be around 36. So 36 into 8 will give you around 288. So you want to correct 288 millimoles of sodium. And you know your 1 liter will contain 513. So to give this 288, how much should you give? Around 560 ml. So you cannot exceed more than this. Again, this is just a derivation of an AM of the AM formula. You can choose which you think is easier. Both are just an approximation and just a guide to tell us how much of a bolus will be too much. I would suggest going with this simplified version. AM formulas, you don't even have to remember it right now. We have apps like MD Calc will directly use the AM formula and tell you how much of a correction and what rate to give it. So you don't have to bother with remembering the complex formulas and all. If you want to do it offhand, this simplified version is much easier, which tells that 1 ml per kg body weight of your 3% saline will cause a 1 milliequivalent rise. So for this 60 kg person, if I'm going to give him 60 ml of 3% NaCl, I'm anticipating a rise of around 1 milliequivalents. So based on that, if I want a rise of only around 4 to 6, how much should I give? This will be a very rough guide. But there is no substitute for checking the serum sodium. You will have to keep monitoring the serum sodium and titrate your correction based on that. Next slide. Now, coming to the next scenario. Basically, this is an elderly female. She has come with an acute change in her mental status with a significant past history of coronary artery disease and hypertension. She's on thiazide medication and aspirin. And on examination, you find that she has some decreased skin turgor, she has some orthostatic hypotension, and she's disoriented. So her lab investigations are given here. You can see that she has severe hyponatremia. Her creatinine is given as elevated, but the BUN does not seem to be very grossly elevated. So we're going to just assume that this is not an acute renal failure. We have been given details like triglycerides, bicarb, and uric acid. We'll just concentrate on the plasma osmolarity and urine osmolarity here as well. So again, she falls under the category of hypotonic uh, hyponatremia. Again, you can see her urine osmolarity is high, so she again falls in the ADH dependent, which is what we are expecting. You've not been told explicitly about her volume status, but you can decipher from the data given. So she has decreased skin turgor. She is found to have orthostatic hypotension, which tells us that this is a hypovolemic patient. Now, in the hypovolemic category, you can see that her urine sodium was not given to us, but there's no mention of any extrarenal loss. We are not told about patient having any vomiting, any third space loss. We're going to assume that her urine sodium will be high if we check it, and it's probably diuretic induced. So this is again a very common scenario you will meet, especially for thiazide diuretics. Thiazide way more than loop diuretics. Loop diuretics are not as notorious for causing hyponatremia. So the thing is, diuretics are the first line treatment of hypertension. They're very cheap and effective drugs, which are commonly used. So in your peripheral centers, government health centers, all will give diuretics, thiazide diuretics as their hypertensive management. So the problem with this is they cause severe hyponatremia. Maybe the patient was newly started on this medication, or maybe the patient had some other precipitating factor that pushed her into hypovolemia, some vomiting, decreased fluid intake, or some third spacing. We don't know the cause, but we're going to assume that it is diuretic induced. So, how are you going to manage the patient? The next slide. So, here first thing we need to remember is we have to withhold the diuretics. The medicine cannot be continued. You want to hold her diuretics. She is in a hypovolemic state. You want to see why is she hypovolemic and hydrate her adequately. Just for the sake of practicing the formula, I've once again given AM formula here. Suppose we want to give this patient 3% NaCl. The change in sodium that will be expected with 1 liter is around 13 milliequivalents. So with each bolus of NaCl that you give the patient, you expect the sodium to rise by around 1.3 milliequivalents. Patient is again having acute symptoms with severe hyponatremia. So definitely you want to give her a bolus. But each bolus you give, you're going to anticipate the sodium concentration to rise by 1.3. So I give two boluses. I know that I'm anticipating at least a correction of around 2.6. You have to immediately recheck your sodium levels. And usually by increasing the sodium to 4 to 6 milliequivalents, you will find improvement in the status of the patient. Whatever symptoms the patient was experiencing, especially altered sensorium, usually improves with an increase of around 4 to 6 milliequivalents. Suppose the patient's status doesn't improve, then this is a time when you'll have to consider other factors that could be making the patient having developed the symptoms. So this is where you'll have to explore possibility of why the creatinine was high for this patient. And not about her correction of hypovolemia. We said she's dehydrated, so definitely we have to correct her hypovolemia. But this is again considering the fact that this is an elderly female with a history of coronary artery disease. So it doesn't mean that you're going to pump her with fluids, try to hydrate her. You'll have to do it cautiously, make sure that she doesn't go into fluid overload. So this is basically example to show you how it's very case based. There is no fit answer. I cannot tell you how much fluid to give her at what rate. It will be all dependent on how much the patient will tolerate. So, even though we're saying correction of hypovolemia, please remember that it will be based on the patient's status. Next case. So this is another elderly male who's come with pneumonia, and on examination, you're given his supine BP and his standing BP. You're told he has some feature suggestive of a consolidation. So he has pneumonia, and his lab investigations are given to you. The next slide will show the lab investigations. So here again, your sodium level is given to be low. He has moderate hyponatremia. Your other electrolytes seem to be fine. His creatinine, his glucose are all fine. Urine sodium has been given. It's quite high. It's more than 20. Urine osmolarity is also quite high. It's 500. So this question has not included the serum osmolarity, but you can derive it from the data given. So this was covered by Jatin in the first class. How can you calculate the serum osmolarity using the sodium, glucose, and the Bun levels? So with the formula, you find the serum osmolarity is low. It's less than 275. So definitely this patient also falls into the hypotonic hyponatremia. And once again, his urine osmolarity is high. So he is also in the ADH dependent group. Now, coming to the volume status of the patient. So the volume status has again not been explicitly told, but they have painstakingly given the supine BP and the standing BP. That was just to tell you there is no orthostatic hypotension. So we're going to assume that the patient is euvolemic here. The urine sodium has been given, it's quite high. So here again, we're coming to a provisional diagnosis of SIADH. Here, one reminder, SIADH is always a diagnosis of exclusion. So in this condition, you will want to look for other causes like your endocrinopathies, your cortisol deficiency and thyroid disease. It was covered in the first class. So basically, you will want to make sure the patient has no cortisol deficiency, patient has no hypothyroidism. And once these are excluded, we have come to the diagnosis of a possible case of SIADH. So patient has SIADH. Next slide. So SIADH is common in elderly who have an acute infection, especially pneumonias caused by Legionella are notorious for causing hyponatremia. So here we assume that is the case in this elderly gentleman. We're not told much about whether the patient has any other symptoms. As Jatin explained, the symptoms could be as severe as your convulsions and altered mental status to something as mild or disregarded as a frequent fall or gait instability that has been noticed recently. So in this case scenario, none of this information has been given to us. So we can't really judge whether the patient is having an acute or a chronic hyponatremia. We'll just assume that it has happened with the infection. So, how will you manage a case of SIADH, which is probably precipitated by an infection? So, the first thing is treat the underlying cause. He has a pneumonia, you want to treat him with antibiotics, give him the necessary treatment. Then comes the part about fluid restriction and your 3% NaCl correction. So here the information is not adequate for us to decide whether the patient falls into the acute or chronic, but definitely he has a moderate hyponatremia. So you will not be faulted for giving. So you'll not be faulted for NaCl. Now, coming to a little bit about the correction, fluid correction in case of SIADH. Again, this Jatin had covered about the fact that you should not give isotonic saline in SIADH because the response is different. So here what happens is in SIADH, basically the response to all the atrial natriuretic peptides and aldosterone are all normal. So whatever sodium is administered will get excreted in the urine, but because the ADH action is inappropriate and persistent, water tends to get retained. So a patient with SIADH, usually we do not give isotonic saline because that will further worsen their hyponatremia. But again, this will be a little bit controversial here because you have an elderly male who has come with an acute infection. Right now, he's euvolemic, but such patients are very prone to dehydration, hypovolemia. So, in such a case, whether restricting fluid, I know we have said treatment for SIADH is fluid restriction, but whether your fluid restriction alone will be enough for this case is something that you will have to take on a case-based management. So, we cannot just say the patient should not take any extra fluids. I want to restrict it to less than 800 ml. You have to consider the fact that patient is having an acute infection. Their oral intake will generally be less. So you should not push the patient into dehydration. So the fluid restriction part is always very controversial. The next slide tells us that another thing we should expect is we might give the patient hypertonic saline, but initially you will note that your serum sodium will be going up to target, it will be rising adequately. But over time, again, remember that his urine sodium was very high, so he'll continue to excrete sodium in his urine. So you might find that later on there will be a drop in the sodium levels again. So in that condition, we have to go back to the fact that we have to aggressively treat the cause for SIADH, and you have to also consider whether you need to use the vasopressin receptor antagonist. So in the acute period, yes, you can give 3% NaCl. Yes, you can give boluses because he has moderate hyponatremia. But remember, because he's SIADH, you have to aggressively treat the cause, and also you have to consider the possibility of use of your vasopressin receptor antagonist. So tolvaptan is available for that. Tolvaptan is not used in the acute period, but to prevent this further drop that can happen, you can use tolvaptan. Coming to the final case scenario, this elderly male again, known case of cirrhosis, who has come with worsening edema, and you find that he has anasarca. His BP in supine position is 110/75, but on standing it drops to 90/65. He's tachycardic when he stands, and you can see that he has ascites and a shrunken liver. So basically, decompensated CLD. And he seems to have orthostatic hypotension. BP has significantly dropped on standing, so he's having orthostatic hypotension. His lab investigations are given, and he's noted to have hyponatremia, again, sodium of 125. The rest of the electrolytes appear normal. His creatinine is mildly elevated. So here you've been given his urine sodium, which is low, and the urine osmolarity, which is high. Just like before, the serum osmolarity is not given, but you can calculate it, and he falls under the category of hypotonic with ADH dependent. So you've been told he's in hypervolemia. So this he comes under the category of hypervolemic with low urine sodium. So due to heart failure or cirrhosis. So his cirrhosis has led to his hyponatremia. So again, this is a very common scenario you'll meet. A lot of patients with fluid overload, especially cirrhosis, will present with hyponatremia. Hyponatremia and cirrhosis is a bad prognostic marker usually. So management of hyponatremia and cirrhosis is again a little controversial. It will be very case specific. But just some things to remember here. Again, we are talking about fluid restriction. Values vary. Roughly, we usually tell 1 liter or less than 1.5 liter per day. The ideal thing here is it should be at least 500 ml less than their urine, which will be practically not possible in most cases because such patients, again, due to excessive ADH, they will have excessive thirst. So when you restrict their fluids, when you tell them less than 800 ml per day, it makes their life actually very miserable. So fluid restriction to as much as possible, definitely yes. Now here the patient is in a volume overload condition. So you would expect that we want to treat his volume overload. So as per the flow chart, we'll want to give him diuretics like Vipin mentioned, we want to give him furosemide. But then you also have to remember that this patient had a significant orthostatic hypotension. There was a significant postural hypotension. So this hypotension will further worsen the hyponatremia because it will result in stimulation of the RAS system. There will be more hyponatremia. So in such a case, at present for this case, it's not wise to give the patient any diuretics you will have to withhold the diuretics. Our aim is to maintain a mean arterial pressure at least above 65, as high as 80. So most of this decompensated cirrhosis patients will be on beta blockers uh, for their portal hypertension. So if the patient is on any of that or on any antihypertensives, you want to withhold all that. You want to try to maintain a mean arterial pressure of at least 65. To assist with the maintaining of the BP, you want to consider infusion of albumin. Of course, here patients who have severe hyponatremia, again, there is no harm in giving your NaCl, your 3% saline as a bolus. But generally, these patients will usually have a very poor prognosis, and hypertonic saline will can aggravate the edema in their anasarca. So it's a little bit of a controversial situation how to manage this case. One thing to remember here is VAP turns are not recommended. If it was a heart failure patient who presented in the same way, VAP turns could be attempted, but in case of cirrhosis and liver failure, VAP turns are not indicated. The other thing that can be done, this patient doesn't have hypokalemia, but many patients with cirrhosis will usually have an associated hypokalemia. So, like Jatin had mentioned, correction of the potassium can help with improving the sodium as well. One more scenario that I have not given example for is hyperglycemia. That is also another common situation you will encounter. Patient with sugars of 600, 700, and their lab investigations reveal a hyponatremia. So again, in the first class, it had been covered about how that is a pseudo hyponatremia. It's not an actual hyponatremia. So as you correct the glucose, you will usually notice an improvement in the sodium levels. So what you can do in such a case is just ensure that the hyponatremia is corresponding to the glucose level. So there's something called a corrected sodium level. For instance, for every 100 milligram deciliter rise of glucose above normal, you expect the sodium to fall by around 2 milliequivalents. So if my glucose is around 600, it is 6 times the normal. I expect my serum sodium to have dropped by at least 12 from my baseline. So if the value corresponds to that, then you think it's related to your hyperglycemia, and management of the hyperglycemia by itself will result in correction of the hyponatremia. So these are the end of the scenarios. The scenarios are a little complicated, I know. But basically, what I'd like to highlight here is that in all these cases, you've been given something about the volume status. So, volume status and the history of the patient has been mentioned. So, using this lab values, we have access to urine osmolarity, urine sodium, plasma osmolarity. You cannot treat hyponatremia with just the lab values. You need a very detailed history and a clinical examination to assess the volume status. The whole flowchart as to what is the probable cause changes depending on the history and the examination, especially the volume status. So in the case scenarios, all that was very straightforward. We told patient is euvolemic, and so it's very easy to follow. But in actual practice, this will not be the case. You'll have to spend time to find the history and examination of the patient. Another thing I'd like to highlight is that what Jatin has told us about osmotic demyelination. So this is a complication that happens. It's not a myth. So although all the flow charts are given aggressively, give bolus of up to 300 ml of hypertonic saline, please remember there they have mentioned sodium monitoring is being done on an hourly basis. So there is no harm in giving you a bolus of sodium, but at the same time, you should remember that you have to keep checking your sodium. So in many of our centers, we will not get values in a span of 1 hour and all. So in that case, you will have to alter your correction based on the values that you get. So in some places, you will see that we give it as a infusion instead of giving it as a bolus. Basically, that's just a way of playing it safe until we have the lab values. The formulas can help you get a rough estimate, but it's not a substitute for checking the actual lab values. Another thing is if the patient, so here again, the scenarios were very straightforward. Patient came with convulsions, sodium was found to be low. In practice, that won't be the case. You'll find a lot of other factors that will be contributing to the patient's symptoms. There'll be hepatic encephalopathy, uremic encephalopathy, septic encephalopathy. So it's not as easy as it sounds. Correct the sodium and all the problems are sorted. So basically, just remember that anytime you find an acute hyponatremia and you think that is responsible for the symptoms, usually by improving to a level of 4 to 6 milliculons of sodium from the baseline, will generally result in resolution of the symptoms. So if symptoms are persisting, I've corrected, my patient came with sodium of 110, I've given a correction, it's gone up to 116, but patient is still in altered sensorium, that's a time when you will have to evaluate for other causes. So that is not highlighted in these scenarios, which will be what you commonly encounter. Other than that, I think everything was very well explained, starting from the physiology. Hyponatremia is a very confusing topic. Each time you read it, you realize more stuff. With Jatin, I realized that I came to learn so much more about hyponatremia. So don't feel discouraged if it seems too much and a lot to handle. You just have to go back and go through everything, especially the physiology part, which he has covered really well. So if you have any doubts, any clarifications, I'd be glad to help.
Thank you, ma'am. Thank you, ma'am, for giving us a practical approach to hyponatremia based on what we've learned. So we'll be uploading this lecture also in YouTube. So and I'll also be uploading a feedback form. So please fill the feedback forms as well. So thank you everyone for attending, and thank you Manju ma'am for moderating the two sessions. And I think we can end the session with them if anyone else doesn't have any doubts.
Thank you, Jatin. It was a pleasure to be involved in this class. Thank you for the opportunity.
Thank you, ma'am.